I think the hour is upon us and our speakers are here. So I think we'll go ahead and get started. So I am Harry Hoare. I am a MedPeds trained, now practicing pediatric hospitalist at Bay State, and I have the privilege of a title called Director of Clinical Reasoning Education for UMass Bay State. And so that gives me the additional honor to introduce today's speakers. I'm calling this another clinical unknown with the clinical problem solvers because this is actually their third time at Bay State, is one reason. They've presented twice clinical unknowns in pediatrics. And also many of you have probably already heard them do clinical unknowns on their podcast. So for you, it may be another clinical unknown with them as well. So none of our speakers today have any disclosures, and the CME code will pop up here. It's VEVFAY. All right, we can go to the next slide, Juice. So let me introduce these guys for the third time. And for many of you, particularly the internal medicine and MedPeds residents, they probably don't really need an introduction, but our speakers today are Doctors Reza Manesh and Rabih Geha, who are also known as the CP Solvers. They're very well known for their incredibly popular podcast, The Clinical Problem Solvers. So speaking about them individually first, Rabih Geha is an assistant professor in medicine at UCSF. He did his undergraduate at Boston College, actually, in biochemistry and mathematics, which is why he's referred to as the mathematician, I guess. He did his internal medicine residency at University of California, San Francisco, as well as a chief resident year, which he completed in 2018. He now works at UCSF in the San Francisco VA in the emergency department and as a hospitalist. Reza Manesh is an assistant professor of medicine in Northwestern. He did his undergrad and med school at the University of Pittsburgh and his internal medicine residency also at UCSF, where he graduated in 2015. So these guys are fairly recently out of training, and they got together to put this podcast together. And amazingly, they've done a lot of stuff in the few years since they have come out of training. Together, they have done over 25 national or international presentations related to diagnostic reasoning. They've published several New England Journal of Medicine clinical problem solving articles. And overall, together, they have more than 50 clinical problem solving publications out there. And that doesn't include their podcast, which has about 30,000 downloads per episode across 143 countries, and their website, which has over 1 million visits in the little bit less than 2 years since it's been up and running. So this presentation today has been a long time coming, listening to their podcast since it was launched exactly 2 years ago, December 9th, 2018. And it was about a year after that that I met them at the Society to Improve Diagnosis in Medicine conference. Last year, invited them to come to Bay State as visiting professors. They agreed to do that, and they were going to come in April. You all know what was happening in April, so the in-person visit never occurred. They did join us virtually in pediatrics to solve an unknown. And then they came back just a few weeks ago to pediatrics again to solve an unknown. And now they are back home in internal medicine land, where once again, we will be having them solve a clinical unknown. Now, the presentations that they've participated in pediatrics, I've been told by many residents and faculty that those are the two best grand rounds that they've ever seen. And like I said, those guys aren't even pediatricians, and that's what the pediatricians think about them. So I'm really excited to see what happens, and they tackle another unknown case here, a medicine case for us all. So to present the case, our medicine chief residents will be presenting the case, and we'll just go through a little bit of the ground rules. So they will present the case in aliquots, and after each aliquot, our discussants will share their thoughts on the case. And the best way to get the most out of this is for you all to sort of pretend you're the discussants as well, and think, what are you thinking? How would you approach this patient? And what would you be saying if you were in the spotlight, you were in the hot seat, trying to solve this case, really being actively engaged. So with that, I will hand it over to Chief Resident Dr. Fatima Ali to start our case.
Thank you, Dr. Kaur. All right, let's just get right to it then. All right. So we'll start with an 89-year-old female who presents with paresthesias and weakness. We'll give you some more information. So this is the first aliquot. A little bit of a background history in this first aliquot. This lady received the flu vaccine 1 week prior to her hospital presentation, and this was a different hospital than Bay State. 2 days after she received the flu vaccine, she developed fever and vomiting with progressive weakness to the point that she was having difficulty getting out of bed or ambulating. She went to her PCP, who diagnosed her with a UTI and started her on nitrofurantoin for the UTI. 1 week later, she developed paresthesias and lightheadedness with progression of weakness. And then at this point, she presented to an outside hospital. She complained of paresthesias in her right lower extremity, and then these progressed to her left lower extremity as well, starting at the toes and then slowly spreading up her legs. Should I pause here or give more information?
Keep going.
So let's talk a little bit more about her outside hospital course. They did some imaging there. A head CT was done, which was normal. A lumbar spine X-ray was done, and that showed extensive degenerative changes with intervertebral disc narrowing. The UTI was now treated with levofloxacin. However, her white cell count trended up significantly from 9.7 to 19.7. And so they kept playing around with antibiotics, and then they were switched to meropenem from levofloxacin. At the same time, her course was also complicated with hyponatremia. Her sodium level was 117 at the outside hospital, and this was suspected to be from SIADH. Hence, this was treated with fluid restriction and salt tablets. With regards to her weakness, her bilateral lower extremity weakness continued to worsen to the point that she was unable to move either leg. At this point, this is day 5 at the outside hospital, she was started on methylprednisolone and transferred to Bay State. So a bit more about her past history. She has a past medical history of asthma, type 2 diabetes, hypertension. She was also diagnosed with invasive ductal carcinoma of the left breast in September 2018, for which she's had a lumpectomy and has been treated with adjuvant radiotherapy with curative intent. Also has a history of bilateral cataracts. Nothing much going on with her social history. She denies any history of tobacco, alcohol, marijuana, or other drug use. With regards to her surgical history, she's had the lumpectomy and she's had cataract surgery. Her home medications include acetazolamide, amlodipine, aproclonidine eye drops, aspirin, atropine, eye drops again, hydrochlorothiazide, latanoprost, letrozole, lisinopril, and timolol. Now, as the last slide for this aliquot, I will talk about her physical exam. Her vitals were essentially unremarkable, and this is at the outside hospital. Temperature of 97.4, heart rate of 80, blood pressure of 117 by 54, and an O2 sat of 99% on room air. I'm only going to focus on the neurological exam because everything else was essentially unremarkable. Her mental status, she was alert and oriented ×3. Her speech was fluent, and she was able to follow simple and complex commands. So with regards to her cranial nerve exam from 2 to 12, her visual fields were full to confrontation in the right eye. She can only see light in the left eye and cannot count fingers. Right pupil is 4 millimeters in size. Left pupil is unreactive, and this is apparently her baseline. Bilateral eyes cannot look up. Her left eye can also not adduct, and this is also reportedly her baseline. Light touch is normal on face bilaterally. Face is symmetric with smile. Tongue and palate are midline with protrusion and elevation, respectively. There's no dysarthria, and her hearing is grossly normal to conversation. With regards to her motor exam, in her upper extremities, she has normal tone and strength and no orbiting or drift. And in her lower extremities, she has decreased tone, and her strength is 0 by 5. With regards to sensation, it's diffusely intact for light touch and vibration in the face and bilateral upper extremities, but she cannot feel light touch from the mid-thoracic level down, which is suggestive of a sensory level. The bilateral lower extremities are insensate to light touch, vibration, and pain. Her deep tendon reflexes are brisk in bilateral upper extremities, normal patellar reflexes, and absent at the ankles, and her Babinski reflex is showing a triple flexion bilaterally, which is essentially flexion at the toe as well as the foot and the knee. And cerebellar exam, all it said was the finger to nose test is suggestive of mild ataxia. So this is a summary slide with everything that I've said up till now. So summarizing all the slides in aliquot 1. I'll take a break here.
Thank you, Fatima. I'm glad you decided to take a break. This is a lot of information. And as always, we're very happy to be here. Maybe what I'll do, because I really want to tackle this piecemeal, because I think that's where most of the learning occurs. It's during the journey, not so much the final diagnosis. And I'll just dance with my brother, Rabih. Maybe, Rabih, I'll just start with the top left aliquot, and then we can go back and forth. I will say step 1 is that we're dealing with a neurologic problem. And anytime you're dealing with a neurologic problem, you want to get rooted in the neurologic DDX equation. Now, what is this neurologic DDX equation? We've learned this from a very dear friend of us, a neurologist. It basically equals localization times time course. So the step 1 is to not only identify that you're dealing with a neurologic syndrome, but based on your neurologic frame, you're going to localize the site or sites of neuropathology. Then step 2 requires incorporating time course. Is it hyperacute, like a vascular lesion? Is it acute, subacute, or chronic? So I'll start with this first aliquot on the left, but I just want to let you know that's sort of the background and and how we're thinking about this problem. So I'll just deal with the paresthesias and a little bit of the background here. When someone complains of paresthesias, they're basically saying that they have symptoms that are similar to pins and needle sensation. These are positive sensory symptoms. And now what we need to do is try to determine where along the neural axis is the site of pathology. Is it at the brain? Is it at the spinal cord? Is it at the nerve root, the ganglia, the plexus, the peripheral nerve? Where exactly is the site of neuropathology? In general, when you have paresthesias, we think about peripheral neuropathies, which come in 3 flavors: mononeuropathy multiplex, and polyneuropathy. We already know that this is unlikely to be mononeuropathy because it involves multiple extremities, multiple distal extremities. So we're either dealing with mononeuropathy multiplex or polyneuropathy. Polyneuropathy tends to be symmetric. So just based on aliquot number 1 up in the left corner, I would be converting this aliquot into acute polyneuropathy. You see, this is different than chronic polyneuropathy. Acute, meaning from hours to days to maybe a week. And for acute polyneuropathy, you can think about Guillain-Barré syndrome and its variants. There's so many variants for Guillain-Barré, and many times Guillain-Barré will have cranial nerve involvement as well. Other possibilities in the acute polyneuropathy include toxins like arsenic and thallium, in addition to acute intermittent porphyria. But here we get the history that this patient was vaccinated a week ago. So whenever someone gets a vaccine, which they should get vaccines, and hopefully we get the corona vaccine sooner rather than later, they can have some kind of immune response to that vaccine that ends up attacking the peripheral nerve. So just based on this top left aliquot, reflexively, I thought vaccine, immune activation, potentially demyelination, and acute demyelinating polyneuropathy. Now what I'm going to do is I'm going to pass the mic to Rabih to discuss whatever he wants, and I'll be happy to take it back anytime.
All right, my friend. Let's. I like this slide-to-slide analysis, and I will say that the role of a head CT in a neurological syndrome is important, and can detect subtle pathology, really ranging from small strokes to cysts in the ventricles, etc. But the primary role of a head CT is to look for blood, large strokes, and hydrocephalus. And I think that the fact that it's normal here is reassuring in two dimensions. One, you don't want to have any of those things. And two, we weren't suspicious of a brain problem to begin with. Although I will say that if you are dealing with a bilateral lower extremity process, a bilateral ACA distribution stroke or a meningioma right here in the middle on compressing on both ACAs can result in that. So that is reassuring in some extent. Urinary tract infections are, believe it or not, one of the hardest diagnoses to make with any confidence in general internal medicine. And that's because the rate of asymptomatic pyuria in older adults is through the roof. And Dr. Ali, do you mind reminding us of her age? It completely slipped my mind as I slowly sipped through this coffee.
So she was 89 years old.
89. So I ask because the older you are, the more likely you have to have asymptomatic pyuria, and the numbers escape me. But at 89, she totally has a very reasonable probability of having pyuria just in her regular old existence, and which means that the diagnosis of a urinary tract infection becomes very complicated without any urinary tract symptoms, and especially if the symptom complex or the laboratory data heads in the wrong direction. In addition to thinking about complicated urinary tract infections, you might have to think about diagnostic complications, which is that this is not the diagnosis in the first place. Here, quite honestly, the hyponatremia caught my attention for the following reason. Most neurological syndromes that you can think of, strokes, demyelinating diseases, CNS tumors, polyneuropathy, etc., are limited to the nervous system alone. Usually, because of immune protection, most neurological diseases occur in isolation. This is why neurologists can practice comfortably without the aid or assistance of a general internist team. They don't need us. We certainly need them, as we do right now, but they don't need us. And you ask yourself, how often does neurology consult internal medicine? This would be a situation where neurology might consult us because of the hyponatremia. It's very rare. So the mere presence of hyponatremia is a clue that there's an unusual systemic phenotype to this, because most Guillain-Barré doesn't have hyponatremia. Most transverse myelitis doesn't have hyponatremia. And so its presence is a signal that there's some sort of atypical phenomenon going on here by virtue of the relative uniqueness of neurological syndromes and their relatively rare association with the requirement of 2 general internists. But it's exciting to see that because we might have some value beyond relying on our dear friend Aaron Berkowitz, who leads our neurodimension at the CP Solvers. So what did this aliquot tell us? It reinforces the idea that a bilateral ACA process is not at play. It brings to question a working diagnosis of a urinary tract infection because of the rate of incidental pyuria in older adults, and it puts a little bit of a systemic sprinkle on an otherwise neurological disorder, which is unusual because most neurological disorders are isolated. And then finally, I will say, steroids are not a bad idea in many instances, and I without more data would never question the judgment of anybody at this point. But I will say that just because you're treating steroids does not mean an autoimmune disorder is removed, which is the primary consideration once infection is excluded. And I say that because of the many things we should consider in rapid paralysis, like Guillain-Barré, like myasthenia gravis, some of them actually get worse with steroids. Guillain-Barré can get worse with steroids. So can myasthenia. So we're going to track the steroids because they complicate things diagnostically. They hide the ability to detect lymphoma. They hide the ability to detect infections, and they can make some autoimmune diseases worse. So we'll have to track that as a possibility. But I'll pass the next slide on to you, Reza.
Thanks so much, Rabih. That was brilliant. As we're trying to go on this journey to localize the sites of neuropathology, and interestingly enough, like when Rabih and I do these clinical unknowns, you really want to try to identify the salient features as you're solving the case. And here we have multiple salient features that must be explained by the final diagnosis, one being the hyponatremia, and the other being bilateral lower extremity paralysis in the sensory level that Fatima presented. As far as this next aliquot in the bottom left, I feel like a radiologist here orienting people to the slide. Really, if you look at the past medical history, basically anyone that ages has the rights to have many of these diseases that this patient has. Bilateral cataracts, hypertension, diabetes are not uncommon in our elderly population, or even for diabetes and hypertension in the middle age group. The invasive ductal carcinoma is one to track. I'm not sure how to relate that right now, but of course, once someone has cancer, they're always at risk of recurrence of that cancer. and metastases or even perineoplastic phenomenon. And as far as the medications, nothing is extremely striking. Of course, people can develop electrolyte abnormalities that can lead to muscle weakness, but nothing is jumping out at me. Rabih, should I move on to the physical exam or do you want to tackle it? Okay. So here, Rabih said already that usually when you have an isolated neurologic problem, you're not going to get much of a systemic flavor. So when we look at the vital signs, we want to see, is this patient systemically inflamed or not? Fever is probably the most specific marker of inflammation, but it's not the most sensitive. So I'm going to be interested in the labs that eventually get revealed to see, is there leukocytosis? Is there elevated ESR, hypoalbuminemia, thrombocytosis, markers of inflammation? Because that would reframe our current problem representation. And now I'll just speak on the abnormalities in the neuro exam, this is a beautiful neurologic exam. Look at that. 6 components from mental status, cranial nerves, motor, sensory, reflex, and cerebellar. That's terrific. For the cranial nerves, let me just ask you really quickly, Fatima, because here you say that the pupil on the left is unreactive. How was the vision in the 2 eyes prior to the presentation?
So from what we know, she is blind in her left eye, and this is her baseline. And there's not a lot of clear history when it comes to this as to when it happened, but apparently it's been present since childhood.
I understand. Okay. That's really helpful to know because, of course, if the pupil was unreactive, then you would think something wrong with the optic nerve, but it's hard to make much of that because this is the patient's baseline. What we see here is that the patient cannot look up. So what is responsible for looking in various directions? It is cranial nerves 3, 4, and 6 through your extraocular muscles. So here, if cranial nerve, and I always have to remind myself, I believe it's primarily cranial nerve 3 that looks up. So then the question becomes, is there an issue at where the cranial nerves originate, which is the brainstem, or their peripheral nerve? For example, is there mass on the peripheral nerve, the neuromuscular junction, or is there something actually obstructing the muscle itself? Here, the fact that it's bilateral suggests it's a very important clue. Either you have a demyelinating process affecting multiple peripheral cranial nerves, or you're dealing with a neuromuscular junction disorder. I think brainstem becomes less likely. And the reason I say that is these cranial nerves are so close to each other, packed in the brainstem. And after I finish the cranial nerve, I'm going to pass the mic back to Rabih. They're so packed close together in the brainstem. So how can you target both, CN3 nuclei and not affect any other part of the, cranial nerve system? That's why it's making me push more towards the junction and to have an obstructing mass on both sides. I mean, it's possible. I think that's less likely based on that CT scan. So mic to Rabih.
Ooh, the mic's getting warmer and warmer, folks. It's becoming harder and harder to hold. And I will say I will layer on to Reza's analysis of the cranial nerve the 3 other prominent features of this case. The one is the cerebellar findings. The other is the sensory level, and then the reflection on some absent findings. So if you just look for a moment at the motor exam and you see that there's essentially flaccid paralysis in the lower extremities, that flaccid paralysis, just paralysis. The immediate question is, what are the reflexes to help you localize it to the peripheral nerves, the neuromuscular junction, or the muscle, or to localize it to an upper motor neuron lesion? But your job is made so easy because you found one of the 3 S's. And one of the 3 S's are sensory level, sacral sparing, and the third S is spirochetes, which I'll explain later. We'll leave that as a teaser for you all. But the first S is sensory level. The second is sacral sparing. Those are 2 pathognomonic findings for myelopathy. And the very fact that you find a thoracic sensory level means this patient has a myelopathy. There is literally no other cause under the sun. The good news is that hypothesis is supported by the presence of bilateral lower extremity weakness and the presence of upper motor neuron findings and mixed with lower motor neuron findings. So you see in the reflexes that they are brisk in the upper extremities, normal in the knee, reduced in the ankles, and then there's, was that a Babinski negative? I'm sorry, I can't, or is that positive?
So it's actually a triple flexion. So flexion at the hip, knee, and ankle with stimulation of the Babinski reflex.
Fantastic. Another, well, not fantastic, but another finding suggestive of upper motor neuron lesion. So here's the problem, folks. When we approach neurology, we try to say, okay, where is the lesion? But nowhere under the sun is there a natural law that says that you only have to have one lesion, and nowhere is it said that you can't have a lesion that is diffuse. So Reza made a very compelling case for ophthalmoplegia, localizing many places, but more likely distally. There's also a case for myelopathy. There's also a case for cerebellar ataxia. And there's also a case to question the role of a thoracic myelopathy because there's brisk reflexes in the upper extremities, which would be incompatible with thoracic myelopathy. So when you look at this exam, you're like, I see signal for the brainstem in the form of cranial nerves. I see signal in the cerebellum in the form of ataxia. I see signal in the thoracic cord because of the sensory level. And I also see signal in the pathology resulting in the upper extremities because the reflexes are brisk. Oof. This whole neuraxis is diseased. How can you simplify that? The most common localization of a diffuse localization syndrome with mixed features is the subarachnoid space. So when you look at this and you're seeing that there's nerves picked off everywhere and there's brainstem problems and whatnot and spinal cord problems, what's the common denominator? The common denominator is the space that it's bathed in, the meninges. So for me, this would prompt me to follow each of those leads, follow the ophthalmoplegia, follow the ataxia, follow the myelopathy, study the upper extremities, but I'd be worried about the common denominator, which is the subarachnoid space that houses the meninges. Could this be, for example, breast cancer in the meninges picking off selective nerves? So in addition to the imaging that we normally jump to, you might jump to an LP quicker if the imaging is negative. We'll pass the mic back to you folks.
All right, thank you so much. So first we started off with some basic labs. So she did have a mildly elevated white count at 19.1. And we don't have the differential up there, but it was a neutrophilic predominance without significant immature forms. H&H were slightly low, normal platelet count. Her chemistry was notable for persistent hyponatremia, which was significantly improved from as compared to the outside hospital where she was 117. Then she also had a mildly elevated BUN with normal creatinine. Inflammatory markers were also mildly elevated. And then we had a whole host of other labs that were checked. So she had a negative ANA, negative Lyme antibody, negative RPR. And then they also looked for some other metabolic causes of potential peripheral neuropathies, which were not really helpful. B12, folic acid, thiamine, copper were all normal. Zinc was just slightly below the lower end of the reference range. And then we did get some imaging. So this is a kind of representative T2 weighted sagittal cut of her MRI. And they interpreted that as extensive abnormal T2 signal throughout the entire central spinal cord from the cervicomedullary junction to T12. There's also mild expansion of the cervical cord with peripheral enhancement from C3 to T3. And again, they demonstrated multi-level degenerative changes, most pronounced in the lumbar spine with severe stenosis at L3 to L4. And exactly as you mentioned, they went forward with an LP fairly early in the hospital course. So the CSF was clear and colorless, only 4 white cells, 331 RBCs, mildly elevated protein at 77, normal glucose, and we have a meningitis encephalitis panel to identify some more common viral and bacterial pathogens, and those were all negative. So in addition to kind of the standard labs that were obtained for the CSF, there's also a host of other labs that were sent off, all of which resulted negative, including toxoplasma DNA, West Nile IgM, VDRL, triple E IgM, aquaporin 4 IgG, CSF culture was negative, and some autoimmune markers, including anti-SSA, anti-SSB, C-ANCA, P-ANCA, and Jo1 antibody were all negative. So with those initial labs, I'll pause there and ask you what you think of these.
All right, Reza, you want to do the same thing? Back and forth?
Sounds terrific.
Well, now we'll reveal the third S, spirochetes, and you see that in the as you think about sensory level, sacral sparing for myelopathy, you can see that Lyme testing and the syphilis testing tells you how much our neurology and general internal medicine friends think about spirochetes from the spinal cord. And absent HSV and West Nile, spirochetes are actually the most common cause of infectious myelitis. So think of the three S's when you're thinking of a problem with the cord. But that's all I'll say about that, since the Lyme and the syphilis testing are both negative. So my reveal of the card of the third S's is prematurely closed. So when you're looking at the first slide, I think that what it does is it reinforces that this is a systemic disease. The white count and the hyponatremia do that. The overwhelming odds are in somebody who's not feeling well that their hyponatremia is mediated by the appropriate action of ADH. Though to do that, we would need urinosms, serumosms, and urine sodium. But I think that's a good operating assumption. The problem is that neurological diseases are more likely to be associated with inappropriate ADH. So as we get to really keep our diagnostic hats on, we don't have to worry about that sodium too much right now. But it does signal the importance of the treatment team to really study whether or not this is appropriate or inappropriate ADH. The truth is, though, that if you're thinking about hyponatremia diagnostically, its association with two systemic syndromes should really give you some diagnostic pause. One is the frequency of SIADH to be paraneoplastic and concomitant frequency of many neurological syndromes to be paraneoplastic as well. So if this turns out to be SIADH, you might wonder, am I dealing with a paraneoplastic neurological syndrome and paraneoplastic SIADH? The other dimension to think about the diagnostic utility of hyponatremia, especially when you see mild accompanying hyperkalemia, is to think about adrenal insufficiency. And why would an 89-year-old patient get adrenal insufficiency without TB exposure? Most 89-year-olds don't get autoimmune adrenalitis, which is the most common cause of adrenal disease in the United States. But metastatic disease of the adrenals is certainly well described, especially in older adults. So if I look at this, I'm like, the big picture view is, wow, these are very smart general internists or neurologists. They're really thinking about the rare causes of myelopathy, which are important: B12, copper, zinc. But they've established very definitively that this is a systemic syndrome with the leukocytosis, and they've gotten me thinking about paraneoplastic syndromes resulting in SIADH and paraneoplastic neurological disease, or probably more acutely important is the hypothesis of adrenal insufficiency, which in an 89-year-old is probably not TB, it's probably not adrenalitis, but maybe metastatic disease to the adrenal, or maybe adrenal infarction from a variety of possibilities. But I'll leave the juicy MRI / really hard part to Reza.
Quick question with regard to the MRI, and this is really what I would be doing in real time. When you spoke to the radiologist, did they mention that it was consistent with myelitis?
They did say it was suggestive of myelitis, and they recommended clinical correlation, if you can believe that.
Well, we're going to try to correlate clinically as best as we can. The reason that I ask that is we know, first of all, I wish that the MRI included the brain for the reasons Rob, you mentioned. And you want to get an MRI of the brain before you do the LP if you're worried for leptomeningeal involvement or pathology, because the LP can falsely cause enhancement on MRI brain. But that's okay. So we'll work with the cervical, thoracic, and lumbar spine. And here's a very important neurologic teaching point. Patients with acute spinal shock can present with flaccid paralysis, meaning they may not have Babinski, they may not have spasticity or clonus or other findings of upper motor neuron. So just because someone doesn't have, hyperreflexia, et cetera, you can't rule out a central cord process. So here we know we're dealing with a myelopathy based on this MRI and based on the clinical presentation of the patient. So the question becomes, how do we think about myelopathy? Well, the way to think about myelopathy is, one, to ask, is there a compressive lesion or not? Meaning, is there something that's impinging the cord or not? And here we don't have any, at least in that thoracic area, of anything that's obvious to the radiologist that's actually compressing that spinal cord. So you step back and now you ask, so what can cause non-compressive myelopathy? Or a more specific term, what can cause myelitis or inflammation of the spinal cord? So now we have to ask, is this patient inflamed or not? Because a differential diagnosis varies. So for this patient with the elevated CRP, with the leukocytosis, I'm going to sort of activate my systemic inflammatory myelitis schema. And for this schema, you can break it down into infections, cancers, and autoimmune diseases. To talk about autoimmune diseases, I like to just think of the 3 S's: lupus, Sjogren's, sarcoid, and then Behçet's can also involve the spinal cord. Nothing about this presentation, the patient's age, I just don't really like the diagnosis of like new lupus or new Sjogren's, and we didn't get that flavor. When we go to the sort of, we also have to consider the demyelinating category, but like Rabih said, these usually don't have signs of systemic inflammation. What am I talking about here? Multiple sclerosis, neuromyelitis optica, and acute disseminated encephalomyelitis, or ADEM. Of these 3, the only one that has a systemic flavor is acute disseminated encephalomyelitis, where those patients actually, they may have an infection that precedes this demyelinating diagnosis. Here you'll see that this patient had a CSF, NMO, and aquaporin 4. That was sent for neuromyelitis optica. So an MS doesn't involve the peripheral nervous system. That's not to say that you don't get sensory abnormalities with MS. In fact, there's something known as the I believe it's called the hub of multiple sclerosis, where you pick off that thoracic spinal cord and literally you feel like there's a band around your chest. With regard to infections, we'll just speak briefly on infections, but this workup is so thorough. And we just recently had a case of West Nile virus at Northwestern, which was very, very interesting. But nothing is popping out, the syphilis, toxo, West Nile. So then we're finally left in the cancer bucket. And that cancer bucket can include metastasis, which we still don't have an MRI of the brain yet, but there's no obvious metastatic lesion of the spinal cord. You can have definitely paraneoplastic phenomenon, and you can even have leptomeningeal involvement. And once you have one flavor of cancer, you can also have other components and other mechanisms by which that cancer causes neurologic deficits. Maybe I'll just leave the CSF to Rabih, since I sort of breached on his territory in the bottom right corner.
Yo, when you breach on my territory, I just give you a hug. So I think it works out okay. A virtual hug, of course. I'm recalibrating because I learned a lot from what Reza just taught us. And I almost want to summarize for my sake, in that the analysis of the LP, I think the LP just as a big picture tells us a lot. Because as Reza taught us, initially, when you're thinking about a myelopathy, which we now prove because there's something wrong with the MRI, the initial focus is to think about 3 things. Is there compression, as Reza taught us? Is there vascular ischemia to the spinal cord? Or is this a myelitis? And Reza used the radiologist to prioritize a myelitis. And the good news is, yes, radiological evidence of inflammation goes a long way, but it's something else to confirm it through inflammation in the CSF fluid. And that's fundamentally what this lumbar puncture does. Even though the protein is, the white blood cell is normal, the elevated CSF protein tells you there's inflammation going on in the spinal cord, in the CSF. Now, how do you know that? The analogy is no different than you seeing a patient with a normal white count, but with a marked polyclonal hypergammaglobulinemia, meaning if you see a patient with a normal white count, but their total protein is 11 and their albumin is 3, and you get an SPEP and it tells you, whoa, there's so much immunoglobulin, you can make the assumption that that patient is inflamed, and as you should. And the same analogy rings true here. It is true, however, that the degree of inflammation is much less so here than it would be if there were CSF pleocytosis, but it reinforces the notion that we should be on the hunt for a myelitis. But there's one caveat, and that caveat is that vascular diseases in the spinal cord result in inflammation. If you infarct the spinal cord for whatever reason, you're going to get inflammation. Now, how could you infarct the spinal cord? Spinal cord infarction is much less common than brain infarction, but it can happen through 3 common mechanisms. One is you have a vertebral artery dissection. That, remember, the vertebral artery actually feeds into the posterior spinal artery. So if you have a problem with your vertebral arteries, you'll dissect into your spinal cord, you'll have ischemia to your spinal cord. So it's important to think about that. The other mechanism is embolic disease, and embolic disease either bland embolism or through tumor embolism, which is a hypothesis we'll have to entertain. And last but not least is the possibility of what's called fibrocartilage embolism. Now that's rare and really doesn't get much credit except when the patient has DJD. And what fibrocartilage embolism is you have little pieces of fibrocartilage in the discs of patients, and sometimes that can embolize into the adjacent artery and infarct the spinal cord. So the focus of this data that has really pushed the case forward has said, this is likely an inflammatory myelopathy, i.e. myelitis, with the caveat that vascular diseases, either ischemic vascular diseases or diseases from an AV fistula, can look a lot like this. And so the focus should probably be to exclude infectious, autoimmune, and malignant causes, which I'll leave to, I'll pass the mic back to Reza to see if he has any reflections on all the negatives. But I'd say the focus is, what is the source of inflammation? Make sure it's not ischemic, like a dural AV fistula or an infarction. And I will leave you with one final pearl as a reflection on the data we had before. Most cancers recur within 5 years, with two notable exceptions: estrogen-positive breast cancer and melanoma. So when somebody has cancer and it's been in the distant past, you can usually reduce the likelihood of its recurrence. But breast cancer and melanoma are two horrible diseases that can return at any time. But with that, I'll pass the mic to Reza to see if he has any additional reflections on the final data.
No additional reflection. I think that someone in the chat had commented that the VDRL and the CSF is not very sensitive for syphilis. I appreciate that comment. I think, in those patients, you can use whether they have a lymphocytic pleocytosis or an elevated protein as a clue to potentially pathology in that CSF. I really have no other comments to add to what Rabih has said. So I'm looking forward to the next aliquot of information. And it seems like we got rotating chief residents, which is phenomenal. Every time I look up, it's someone new. The case is challenging enough.
All right, so I'm Anusha Bhat. I'm one of the chief residents as well. So moving on. So I'm going to be presenting the next few days about what happened to the patient over the next 1 to 2 weeks. So her symptoms continued to progress. She continued to have flaccid paralysis in the lower extremities, but her upper extremities was pretty much normal, except for a few paresthesia complaints that she mentioned. There continued to be loss of sensation at T6 to T8 and below. She had some mild hypoxia requiring nasal cannula, but her NIFs were pretty much normal, so she didn't qualify for intubation at that point of time. We worked up hyponatremia, and upon evaluation, we found out that she was hypovolemic, so we gave her some IV fluids that corrected her sodium. Neurology at that point of time was considering a demyelinative disorder and myelitis of unclear etiology, so they recommended high-dose steroids for the patient, and we started her on methylprednisone 1 gram once daily for the next 5 days. However, that did not improve her clinical symptoms at all. We repeated MRI of her brain as well as spine on day 10, and there was an interval decrease in the swelling of the spinal cord with interval improvement of diffuse cord signal abnormality. There were no new cord enhancements. Of note, the brain MRI did not reveal any major abnormalities, so that was all within normal limits too. To just answer the question that you had previously asked about CSF cytology, so we did send it out and it was negative. And because she had no symptomatic improvement with high-dose steroids, we were considering her for IVIG, but she had clinical CHF at that point of time, so she was volume overloaded, so we ended up offering her plasma exchange therapy without much improvement in clinical symptoms either. So here is a summary.
Anusha, you came at the best part, the most exciting part. So since we have like 15 minutes left, I want to just take 2 minutes. Everyone, put your money down, think about this case, write down what your hypothesis is. At the same time, Rabih and I will communicate via telephone, and then we'll be back to give you our final answer. So in 2 minutes, we'll be back, okay?
Perfect.
All right, we are all back. Hopefully, the audience is more confident than Robbie and me. What I'm going to do is I'm going to set it up. I'm going to set up the problem representation for Robbie to take us home with our final diagnosis. But we had a patient who went to her primary care, got the influenza vaccine, then later developed paresthesias that was complicated by flaccid paralysis in the lower extremity and a sensory level at about the nipple line, a little lower towards the umbilicus, who had a thorough workup with a MRI showing extensive thoracic cord myelitis. And the CSF was not too convincing of a specific diagnosis, be it infection or cancer. And that's sort of the frame we have. What we thought was the hyponatremia was a signal. It ended up being a bystander. So we'll see what Robbie has to say.
Ooh. Come with me under the bus, please. I love these exercises, and Reza, I know, shares that passion to equal, if not higher proportions. And I will tell you that I can totally see a number of diagnoses being compatible with the data that we have. And I think the learning is maximal now, because whatever this answer turns out to be, I guarantee you that an alternative answer could have turned out in this case. And so the real truth is representing the problem well. And you just heard that. You just heard essentially Reza saying this is an inflammatory myelopathy. And I just wanted to highlight a couple of the gaps. The gaps are that the ophthalmoplegia we're ignoring, the cerebellar ataxia we're ignoring. Now, those may be signal, but we completely ignored those. And so we're really taking the myelitis as a working hypothesis. And myelitis, infection, autoimmune malignancy. The infection hypotheses we said are West Nile, HSV, and the spirochetes. They're much less common causes of infectious myelitis, but there's no dominant signal for those. Cancer, for sure, either in a paraneoplastic form or a direct invasion, but we found no evidence of cancer systemically or in the CSF. So the focus should be on autoimmune diseases. The problem is there are really four categories of autoimmune diseases in the CSF. There's systemic diseases, the three S's that Reza taught us, lupus, sarcoid, and Sjogren's. There's demyelinating diseases, there's antibody diseases, and there's vascular diseases. Systemic diseases, the only one at play is sarcoid, really, frankly. Why? Sarcoid can cause an NMO-like lesion in the central cord, and in 10% of patients just begins in the central nervous system. So sarcoidosis has to be at play. Demyelinating diseases, this MRI is classic for neuromyelitis optica. It is a longitudinal expansive lesion in the central cord. There's two problems with the NMO hypothesis. One is that 75% of patients have the antibody positive, 75, not 100%. But the other whole is that there's no other signatures of NMO. There's no no evidence of optic disease, no evidence of disease in the next to the fourth ventricle, etc. The antibody hypothesis is very plausible, and I think an antibody panel may reveal the final diagnosis. But the money may be in the vascular category. Why? The patient, of all those syndromes, the patient should have some improvement with the steroids. Some. The fact that there's no improvement with steroids makes us wonder whether this is a mimicker of myelitis, and whether, in fact, you're dealing with a vascular pathology. When you look at reviews of mimickers of NMO, of mimickers of central cord pathology, number 1, 2, and 3 are idiopathic transverse myelitis, which this could be, sarcoidosis, which this could be, but also a dural AV fistula. Now, a dural AV fistula is really important to think about because venous engorgement, because of arterial blood flow going into a vein, results in leak of capillaries, which looks just like myelitis. That's what the inflammation is leak of the capillaries. So I think that really whoever is taking care of this patient has a very hard job because there are many diagnoses that are compatible with it. But I don't have the knowledge base to be confident, but in talking with Reza, I think that the most important thing to exclude is a mimicker of myelitis, which is a dural AV fistula. And the way you do that is the most definitively through a spinal angiogram, but you might be able to review the MRI with radiology because they may see subtle flow voids to give you that guidance. Thoughts, Rez? Anything to add?
That was wonderful. All right, so without further ado, we'll stop teasing everyone. A diagnostic test was performed.
Wow, this is such a tease.
Serum test demonstrated presence of anti-aquaporin 4 antibody. So serology confirmed the diagnosis of neuromyelitis optica, DeVick's disease. And we heard you guys say that a million times over. So we might even give this to you, you know. Just going a little bit over the diagnostic criteria. So there's 3 diagnostic criteria. You need to have at least one core clinical characteristic. And in this patient's case, the core clinical characteristic that would fulfill this is acute myelitis, which she did have. You should have a positive test for aquaporin 4 IgG, which she did have, and then exclusion of alternative diagnoses, which is essentially what we were doing for the past hour. The illness script for this disease, so it's just a table that summarizes essentially how a typical patient might present. It's an idiopathic inflammatory demyelinating and necrotizing disease with predominant involvement of the optic nerves and spinal cord. It's more prevalent in areas with Black, Asian, and Indian populations as opposed to Caucasian populations, which you can see in MS. The median age at onset is 41 years in the relapsing group and 29 years in the monophasic group. So this patient's age and age of onset of 89 years was kind of unusual. And there's definitely a female preponderance with a ratio of about 3 to 1. Salient signs and symptoms include acute transverse myelitis, optic neuritis. Sometimes you can have brainstem symptoms due to medullary involvement, which is called the area postrema clinical syndrome. And that can present with nausea, vomiting, or hiccups. If you recall, this lady did have some vomiting and nausea initially at her course at the outside hospital. Now we're trying to correlate everything to this diagnosis. It might not be, but it makes some sense. And then diagnostic criteria, so NMO IgG antibody, which is the aquaporin 4 IgG antibody, and then an MRI showing longitudinally extensive spinal cord lesions. So like you said, the MRI was pretty classic for NMO in this patient, and you would likely see longitudinally extensive spinal cord lesions that extend over more than 3 vertebral sections. The treatment would be, acute treatment would include high-dose IV steroids and plasma exchange therapy. One interesting point that we wanted to make at the end of this was this lady her CSF was negative for NMO aquaporin IgG antibody. And studies have shown that the clinical utility and sensitivity of CSF aquaporin 4 IgG is not as much as serum IgG aquaporin 4. And essentially, that's what clinched the diagnosis in the end. What happened was she stayed in the hospital for another 27 days, didn't really have any improvement in her symptoms. However, over the course of the next year, there has been trace improvement. Her strength testing is now 1 to 2 at the hips, 2+ at the knees, and 3 to 4+ at the ankles. But unfortunately, she's still wheelchair bound. Over to you guys.
I will say, I think Bay State might be one of my favorite places to discuss unknowns. Look at this, a slide with a cognitive autopsy. I mean, that we don't have to request to do a cognitive autopsy. That was an incredible case that you presented. Thank you so much. I'll do my cognitive autopsy and then pass the mic to Rabih. I think, when you're doing a cognitive autopsy, you want to see where the lesion was. Was it a fund of knowledge? Was it the way you were framing the patient? I'm very proud of the way we framed this patient because this entire journey was localizing the site of neuropathology. And I think one last pearl is that sometimes patients who you think have acute polyneuropathy, in fact, have a myelopathy, and that's on the differential diagnosis. So I'm very proud by the way that we framed and localized the site of neuropathology. Here, what you see is a gap in our illness script for neuromyelitis optica. So I misled Rabih because I said, that CSF aquaporin is negative. I don't think it's NMO, spectrum disease. But in reality, we just learned from you, Fatima, that no, send a serum test. So for me, my cognitive autopsy is that there's a gap in my illness script for neuromyelitis optica spectrum disease.
I would add another gap to Reza's cognitive autopsy, which is he thinks he misled me when it's not 100% inaccurate.
Robbie, I thought you said you're going to add another deficiency to Reza's illness script for NMO. I was like, man, it's just piling on. I just got it wrong, and you're adding to the fire.
Never, 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 never. Yeah, I think it's absolutely humbling. And I think at the end of the day, what I could read in a paper maybe 5 times over that the serum antibody is better than the CSF antibody for equine, which is the major growth. But I will never, never, ever learn that lesson better than the way we learned it all together today. So if you had it right, good for you. You'll probably get it reinforced by the fact that Reza and I got it completely wrong. So you're welcome. And if you had it wrong, well, join the club. And I would say that this is the value of doing cases, is to really not just see the gaps in your knowledge, but also have them reinforced in a way that is likely to stick way more than others. And at the risk of a little bit of self-promotion, I tell you that Reza and I do this once a week, every week, and we put together RLR cases, and we do this kind of conversation once a week. So I'm going to paste the link in the chat and have you consider joining us. So if you want to listen to a RLR, Reza and I hanging out and doing this, you can do it once a week. And we would love to join you. And most people comment and reflect on the cases. And so we hope that you'll learn more and more about NMO as you reflect on this case, and more from hanging out with us on RLR.
Thank you so much for joining us. We're so honored.
Yeah, thanks a lot, guys. Another great performance. And I will point out one of those RLR episodes at that link there is the one we did a couple of weeks ago in pediatrics, which I think many of you will also find to be a fascinating case and relevant to internists. And again, you guys, you do so much for the clinical reasoning world out there, and I really appreciate your grace and you're pointing out that getting the case quote unquote wrong it's really not about the final answer. It's about what you learn from the case, and you learn a lot. Probably some of our best learning comes from times when we challenge ourselves, we put ourselves out there, and we're not quite right. As long as the process was good, it was still valuable, and we end up learning quite a bit. We all learned, I can tell from the chat, lots of folks have not only learned a lot from you guys today, but have been learning a lot from you from all the work that you do otherwise. So thanks again, and I hope we can keep up our relationship with you guys in Bay State and down the line.
Only under one condition, Harry. Next time you present us an E. coli urinary tract infection, we need to get one right for our confidence before we come back.
No can do.